بسم الله الرحمن الرحيم. السلام عليكم. Good afternoon, everybody. Today, inshallah, we're gonna have 4 lecture. First lecture about pathophysiology of the coronary artery disease, and second lecture about myocardial infarction and indication for revascularization. Third lecture about syntax trial, and at the end we have case discussion about stable coronary artery disease. Wish all the best for the presenter and feel free to ask them at the end of the lecture. We're starting now with Dr. Sarah and lecture about pathophysiology of coronary artery disease. Dr. Sarah, are you ready?
Yes, inshallah.
Please show your slides and start.
Is the slide clear for everyone?
Yes.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I'm Sarah Labon, cardiac surgery resident R2. Today, inshallah, I'm going to talk about the pathophysiology of coronary artery disease. Okay. We will talk about the epidemiology, definition, risk factors, pathophysiology, cardiac repair, and a small talk about the role of statin in atherosclerosis. Starting with epidemiology, coronary artery disease accounts for approximately 610,000 deaths annually, estimated in 1 in 4 deaths, and is the leading cause of mortality in the United States. According to the
Sarah?
national... Yes.
Do you have a consultant with you on today's presentation?
No, unfortunately, today I don't.
Okay, so we have a few invited consultants. You can ask them if you have any comments. One of them is Dr. Felix, and I'm not sure about the others. But anyway, I'll be also around if you need any help. Thank you.
Thank you so much. Thank you, Doctor. So continuing, according to the national-wide survey, Saudi Arabia has a coronary artery disease prevalence of 5.5%, which is higher than in China, 2%, India, 3%, in Europe, 5%, but it's lower than United States with 6.7% and Egypt, 8.3%. Coronary artery disease defined as a narrowing of the coronary arteries that prevent adequate blood supply to the heart muscle that is most commonly caused by atherosclerosis. So, and by definition, it's an abnormal accumulation of the lipid or fatty substance in the lumen of the coronary artery, leading to an imbalance between the myocardial oxygen supply and demand, causing a cardiac dysfunction, arrhythmias, myocardial infarction, and sudden death. For the risk factor, generally, a modified risk factor will include a high cholesterol level, high blood pressure, smoking, diabetes, metabolic syndrome, mental stress, obesity, and lack of physical activity. With an unmodified
Sarah?
Yes.
I'm sorry. Are your slides advancing? Because I don't see anything. I just see pathophysiology of CAD.
Oh, really? Oh, just okay. One second.
Sarah, you need to do another screen sharing.
What about now? Is it advancing?
Yes, now we see the
Close the screen sharing, then open it again on the presentation.
Okay, I'll stop. Can anyone see the slides now?
Yeah,
Yeah,
now it's
now.
good.
Okay, thank you. Okay, moving on from the risk factor. Okay, so let's start with atherosclerosis. It's a process that is initiated by endothelium activation, followed by a cascade event, which implies the vessels narrowing and activation of inflammatory pathways, leading to atheroma plaque formation, altogether result in a cardiovascular complication. Starting with the first step of the pathophysiology, the endothelial dysfunction. When endothelial cells lose their ability to maintain hemostasis, vessels wall are predisposed to vasoconstriction, lipid infiltration, leukocyte adhesion, platelet activation, and oxidative stress, including an inflammatory response as the first step of atheromatic plaque formation. Hemodynamic forces constitute a local risk factor of atherogenesis, where the lesion-prone regions are mainly located in the area where the laminar flow is disturbed. In the presence of factors as hyperlipidemia, hypertension, smoking, or diabetes, nitric oxide production is reduced, promoting a further endothelial dysfunction. As it's known as endothelial-dependent vasodilatation, it originally promoting smooth muscle fiber relaxation and maintaining metabolic hemostasis. In the next step, accumulation of the LDL in plasma favors transendothelial infiltration of circulating LDL to the intima. Once in the subendothelial space, trapped LDL particles are oxidate and become the key inflammatory component that promote the atherosclerotic plaque development, as you see in the picture in the first and second step. In the leukocyte recruitment, the normal endothelial cell generally resists adhesive interaction with leukocyte. But after endothelial injury, leukocyte will adhere to the endothelium and move between the endothelial cell junction and penetrate through it in a process called transcytosis to enter the intima, where they begin to accumulate lipid and become foam cells. Activated endothelial cell induce a selective monocyte recruitment into the intima in the process through rolling, adhesion, activation, and transmigration held by chemokines. Once in the intima, monocytes are differentiated into macrophages that can be polarized to M1, the pro-inflammatory, and M2 anti-inflammatory phenotypes, with M1 predominating. In the next step of fatty streak, the monocyte, once recruited to the arterial intima, it can imbibe lipid and become foam cell or lipid-laden macrophages. Now, scavenger receptors appear to mediate the excessive lipid uptake characteristic of foam cell formation. Once macrophages have taken up residence in the intima and become foam cells, they can replicate even more and accumulating and end up in forming fatty streak, with the smooth muscle cell migrating from the medial layer to the intima. In the last step of plaque formation, during a fibrous plaque development, atheroma plaque undergo a transition from the fatty streak to the intima, growing by the presence of so-called cell-free and lipid-rich area known as the necrotic core. To stabilize the plaque, the necrotic core is covered by a fibrous, thus developing a fibrous cap, which serve as a structural support. Finally, a bone-like formation within the plaque and local inflammatory regions decrease in collagen fibers and synthetic smooth cell death, yielding a relatively acellular fibrous capsule initiates the calcification process of the plaque. In the plaque rupture and thrombus formation, when the plaque fissure or ruptures, the subendothelial space is exposed to blood, triggering coagulation process to cover the wound. Platelet activated and aggregated with activation of coagulation cascade, leading to thrombus formation. The atherosclerotic lesion expands, leading to a lumen constriction with a reduction of blood flow in the coronary arteries, generating an ischemic cardiomyopathies. Detachment of the thrombus will lead to circulating impulse to eventually lodge in the distal arteries, obstructing blood flow, leading a local ischemia, organ dysfunction, and potential infarction. Here's the mechanism that causing coronary thrombosis, resulting from either superficial erosion versus a fibrous cap rupture. So in the left side, thrombosis caused by erosion, it's associated with a wide thrombus with enough extracellular matrix that with a limited expansive remodeling. This erosion more commonly seen in non-STEMI. But in comparison to the right side, thrombosis resulting from rupture, usually associated with a lesion with a thin fibrous cap. Such thrombi have more of the character of red fibrin-rich clot. It triggers a tissue factors promoting thrombosis with an outward remodeling occlusive thrombus, which commonly more seen in STEMI case. About the plaque vulnerability, it's a concept that is called vulnerable plaque. It's identified as the one that at high risk of causing thrombotic complication and prone to patient to acute coronary syndrome, which characterized with a thin fibrous cap and a large necrotic core populated by numerous inflammatory cells and macrophages infiltration with a relatively lacking of a smooth muscle cell. So finally, the phases of cardiac repair after MI. Early after MI, tissue injury and necrosis initiate the inflammatory phase, consisting of a dynamic recruitment of several immune cell subtypes. But after around 4 days, this transition to a reparative and proliferative phase with a shift of immune cells polarity toward immunomodulation and resolution, myofibroblast proliferation, collagen deposition, and scar formation with neovascularization, thereby resulting in a wound healing. Regarding the role of statin in atherosclerosis, although a heart-healthy lifestyle is the foundation of the treatment of atherosclerosis, but as a lipid and lipoprotein have considerably respected contribution to the atherosclerotic process, with a direct implication on the prognostic aspect, they become an important major therapeutic target. In the 2019, the American Heart Association guideline on the primary prevention of a cardiovascular disease, we will have a small look about the role of statin here in the primary prevention. In a young patient up to 19 years old, the focus mainly going to be about the lifestyle modification. Unless there is a diagnosis of a familiar hypercholesterolemia, then a statin should be considered. In patient age 20 to 39 years of old, statin would be recommended when the LDL level above 160 milligram per deciliter. But in patient age from 40 to 75 years of old with an LDL level from 70 to 190 milligram per deciliter, and these patients are not diabetic, a risk assessment should be used to consider the statin therapy. So the risk assessment will be the bold cohort risk predictor, 10 years risk of the first atherosclerotic cardiovascular disease event. So in case of low risk, list type 5%, and emphasizing in the lifestyle modification will be a class 1 indication. But in patients with a borderline risk from 5 to 7.5%, a risk discussion regarding the use of moderate statin therapy will be a class 2B. With an intermediate risk from 7.5 up to 20%, it's favored the use of a statin, a moderate statin as a class 2B, as a class 1, sorry. With a target LDL reduction level in 30 to 49%. With the final group with a high risk, more than 20%, an immediate initiation of a statin with a target LDL reduction in more than 50% will be a class 1 indication. But if you can see up there, in patient with an LDL level more than 190, and this patient without the need of a risk assessment, a high statin should be immediately started with a class 1 indication. But in patient diabetic with the age of 40 to 75, also a moderate statin can be used without the risk assessment as a class 1 indication. In patient aged from above 75 age, again, we're going to use the risk assessment to establishing for the use of a statin. So that concludes my presentation about the pathophysiology of coronary artery disease. Thank you so much for listening.
Any questions for Dr. Sarah regarding the pathophysiology? So we'll take a break for 10 minutes, then resume the next lecture.
Sarah, somebody was commenting that this was one of the best presentations that we have heard in this platform. So thank you so much, and keep up the good work.
Thank you so much, Doctor.
So we'll resume the rest of lecture after 10 minutes. Thank you. We're starting the second lecture about myocardial infarction and indication for revascularization.
Okay, so Assalamu alaikum. My name is Hani Barnawi and I'm R2 resident in King Faisal Specialty Hospital, Jeddah. So my topic for today is myocardial infarction and indication for revascularization. These are going to be my objectives for today: introduction, MI and its types, pathophysiology, etiology, prognosis, clinical presentation, workup. Lastly, will be the management with the guidelines for revascularization. So a brief introduction: myocardial infarction is the irreversible death of heart muscle secondary to prolonged ischemia. Also, the MI is a syndrome that can be recognized by a set of symptoms supported by the laboratory work, ECG, and the ECG findings. According to the fourth universal definition of MI implemented by the Joint Task Force, MI is diagnosed when either of the following two criteria are met. First one is the detection of an increase or decrease in cardiac biomarker values, especially the troponin, with at least one value above the 99th percentile associated with one of the findings of symptoms of ischemia, new or presumed new ST or T wave changes, or new left bundle branch block, development of pathological Q waves on ECG, imaging evidence of new loss of variable myocardium, or new regional wall machine abnormality. Lastly, identification of an intracoronary thrombus by angio or autopsy. Second is the cardiac death with symptoms suggestive of myocardial ischemia and presumed new ischemic changes or new bundle branch block on ECG. The clinical presentation usually results from an imbalance in oxygen supply and demand, which is most often caused by a plaque rupture leading to the acute coronary syndrome. MI is a broader is a spectrum of the acute coronary syndrome, which are either unstable angina, non-ST elevation MI, or ST elevation MI. The ST elevation seen on ECG reflects an active and ongoing transmural myocardial injury. Without immediate reperfusion, the STEMI patient will develop Q wave. For the types of MI, according to the Joint Task Force, it classified it to 5 types. Type 1 is the atherothrombotic coronary artery. Type 2, MI secondary to an ischemic imbalance. Type 3, MI resulting in death when biomarkers values are not available or could not be obtained. For type 4A, MI related to PCI. 4B related to stent thrombosis. For 4C, MI related to instant restenosis. Type 5 is MI related to CABG. For the pathophysiology, the pathophysiology is either partial or complete coronary occlusion. Partial coronary occlusion leads to decreased myocardial blood flow, leading to supply-demand mismatch. It will result in myocardial ischemia. Usually affect the inner layer of the myocardium, subendocardial infarction, and typically manifest as unstable angina or non-STEMI. For the complete coronary artery occlusion, impaired myocardial flow, sudden death of myocardial cell, leads to full thickness infarction or transmural infarction, typically manifest as STEMI. Evolution of MI and ventricular remodeling. Severe loss of the ability of the heart muscle to contract can be observed as early as 60 seconds with the persistence of oxygen deprivation, the irreversible damage may occur and can be seen within 20 to 40 minutes up to several hours. The typical MI initially manifests as coagulation necrosis that is ultimately followed by healing process, characterized by forming myocardial scarring, known as myocardial fibrosis, and then remodeling, which is the ventricular change to a more spherical shape. Despite being an irreversible process, ventricular remodeling is a regulated process. For the etiology, atherosclerosis is the disease primarily responsible for most, as we said before, for the most of acute coronary syndrome. Plaque rupture and erosion are considered to be major triggers for coronary thrombosis. Within the coronary vasculature, flow dynamic and endothelial stress are implicated in the pathogenesis of vulnerable plaque formation. The culprit regions that are particularly prone to rupture are atheromas containing abundant macrophage. We have modifiable and non-modifiable risk factors for atherosclerosis, which include the non-modifiable, of course, the age, sex, and family history of premature coronary artery disease. For the modifiable, like smoking, hypercholesteremia, dyslipidemia, diabetes, hypertension, obesity, especially the abdominal obesity, sedentary lifestyle, poor oral hygiene. Also, there are non-atherosclerotic causes of MI, which include the coronary occlusion secondary to vasculitis, ventricular hypertrophy, coronary emboli, coronary trauma, primary vasospasm, drug use, arthritis. All these can lead to can all under non-atherosclerotic causes. For the pediatric coronary artery disease, we have Marfan syndrome, Kawasaki, Takayusu, and progeria, all seen in pediatric. For the prognosis, better prognosis is associated with the following factors: successful early reperfusion. Within 30 minutes patient arrival, fibrinolysis within 30 minutes upon patient's arrival, or patient arrival to PCI within 90 minutes. Preserved left ventricular function, and short-term and long-term treatment with beta blocker, aspirin, and ACE inhibitor. Poorer prognosis are associated with the following factors, such as advanced age, diabetic, previous vascular disease, increased TIM score for unstable angina and non-stelivation acute coronary syndrome, delayed or unsuccessful reperfusion, poorly preserved left ventricular function, evidence of congestive heart failure or frank pulmonary edema, elevated BNP and CRP levels. Also, involvement of ECG lead AVR. It has been shown that five baseline parameters at presentation of patients with acute MI accounts for 90% of the prognostic predictor of 30-day mortality. These are the age, systolic blood pressure, and KILIP classification, heart rate, and anatomical location of the MI. For the KILIP classification of acute myocardial infarction, it can predict the 30-day mortality and in-hospital mortality. For class 1, the 30-day mortality will be 2 to 3%, and in hospital will be less than 6%. For class 2, consistent with mild to moderate heart failure, the 30-day mortality will be from 5 to 12%, and in hospital mortality will be less than 17%. For class 3, the pulmonary edema, and class 4, the cardiogenic shock, for 30-day mortality, both will be from 10 to 20%. As for in-hospital mortality, pulmonary edema will increase the mortality to 38%, while cardiogenic shock will increase the mortality rate to 81%. The clinical presentation. History: patients with typical acute MI usually presents with chest pain and may have prodromal symptoms in the day preceding, but typically STEMI may occur suddenly without warning. The typical chest pain of acute MI usually intense and unremitted, 30 to 60 minutes. Retrosternal, radiates to the neck, shoulder, and jaw. For the chest pain is usually described as substernal pressure sensation, perceived as squeezing, burning, or even sharp. In some cases, patients do not recognize the chest pain and have unusually high pain threshold, or have a disorder that impairs pain perception and may result in a defective vaginal warning symptoms. Elderly patients with pre-existing altered mental status or dementia may have no recollection of recent symptoms and may have no complaints whatsoever. For the initial rapid evaluation should include obtaining a brief history and performing a focused physical examination, severe risk assessment score, and clinical prediction algorithm, such as to predict in patient with ACS, such as the TIMI score and the GRACE. For investigators have also proposed a novel risk scoring system, such as CHAD 2A and CHADS 2A 2S and FAST CF. Other symptoms of myocardial infarction include the following: the anxiety, commonly described as sense of impending doom, pain or discomfort, lightheadedness, cough, nausea, vomiting, profuse sweating, shortness of breath, wheezing, fullness, indigestion, or choking. Upon physical examination, the vitals, heart rate might be will be tachycardic, irregular rhythm, bradycardic, unequal palpable pulses, depending on the cause. Blood pressure, hypertension, or hypotension. For the respiratory, it will be increased. For the temperature, it will be normal, but fever may occur from 24 to 48 hours. Neck veins might be distended if inferior wall was involved, along with RV. The heart, lateral displacement of the apical impulse, S4, soft S1, new MR, holosystolic murmur, pericardial friction rub. For chest, rales or wheezes due to pulmonary venous hypertension, abdomen, hepatojugular reflux, pulsatile abdominal mass. For the extremities, peripheral cyanosis, edema, pallor, delayed rise, and delayed capillary refill. For the workup, the objectives of the laboratory workup is to determine the presence or absence of myocardial infarction for diagnosis and differential diagnosis. Also for the imaging, to characterize the locus, nature, and extent of MI, to detect recurrent ischemia or MI, and to detect early and late complications of MI. Lastly, to estimate the patient's prognosis. So ECG, lab work, especially the cardiac troponin, CBC, comprehensive metabolic panel, and lipid profile. For the ECG is the most important initial evaluation, as the expert medical society and organization have implemented the importance of obtaining a 12-lead ECG in a timely fashion. It should be less than 10 minutes upon presentation. And the ECG should be performed on any patients who are older than age of 45 and experiencing any form of thoracoabdominal discomfort, including new epigastric pain or nausea. For the younger patients, ECG should be performed once suggestive of suggestive symptoms are present with high risk for early coronary artery disease. For the different ECG abnormalities, the high probability of ECG features of MI, the ST segment elevation greater than 1 millimeter in two anatomically consecutive leads, and the presence of a new Q wave. For the intermediate, ST depression and T wave inversion, other non-specific ST T wave abnormalities. For the low probability of MI, either it can be normal ECG. Localization for the area of infarct. Here a picture that can help with the V1, V2, usually anterior septal, and the anterior will continue in V3 and V4. V5 and 6 are the low lateral, and 1 AVL are the high lateral. For the inferior, 2 lead 2, 3, and AVF. The characteristic ECG changes may be seen in conditions other than acute MI. It can present in, it can be as persistent ST elevation in case of previous MI and left ventricular aneurysm. ST segment changes, misplaced precordial leads, early repolarization abnormalities, false Q wave in hypertrophic cardiomyopathy, substantial T wave inversion as in left ventricular hypertrophy, the QT segment prolongation as in seen in ischemia or electrolyte disturbance, the saddleback ST segment elevation, congenital predisposition, or could be arrhythmia. ST depression and T wave changes as in non-STEMI. Patients with permanent pacemaker may be confused. Confound recognition of STEMI by 12 lead ECG. Cardiac biomarkers. The cardiac biomarkers are troponin I and troponin T, creatinine kinase, and myoglobin. Serial measurement of cardiac troponins after the initial level is obtained at presentation. It should be serial from 3 to 6 hours. 3 to 6 hours after symptoms onset is recommended. If initial level are negative, additional measurement beyond the 6-hour mark should be obtained also, especially with high suspicion. Cardiac troponin, highly sensitive assay can now detect the cardiac troponin with high degree of certainty. The serum level usually increases within 3 to 12 hours from the onset of the chest pain, and it peaks at 24 to 48 hours, and then normalizes to the baseline over 5 to 2 weeks. The baseline measurement troponin followed by serial measurement of troponin 3 hours afterward should be performed. The measurement of BNP is not recommended for the diagnosis of MI. For the other lab studies, blood oxygenation, ABG or VBG, for looking for hypoxia, might be due to pulmonary congestion, atelectasis, or ventilatory impairment. CBC to rule out anemia, to see the leukocytosis and platelet count. Chemistry for the electrolytes and the lipid profile. Cardiac imaging. Imaging may help to define the anatomy and degree of myocardial perfusion abnormalities. Highly probable or confirmed ACS, urgent coronary angiograph, should be done. The multi-detector CT, coronary angiograph, it's an alternative to invasive angiograph. MPI with SPECT or PET scanning, but not done routinely. The ECG, the echo is highly recommended, looking for new regional wall motion abnormalities. The management. Overview of the management. As a general rule, initial therapy of acute MI is directed toward restoration of perfusion as early as possible. It is very important to distinguish whether the patient is having STMI or non-STMI. Inhibition of pro-protein converts the PCSK9 has emerged as a promising target to reduce the residual cardiovascular disease risk. In December 2017, the FDA approved it for the prevention of strokes, heart attack, and coronary vascularization. AHA and ACC clinical performance and quality measure for adults with STEMI and non-STEMI. Statin use for patients with acute MI. Evaluation of left ventricular ejection fraction, P2Y12 receptor inhibitor prescribed at discharge, immediate angiograph for resuscitation out of hospital cardiac arrest in STEMI patients, non-invasive stress testing before discharge in conservatively treated patients, early cardiac troponin measurement within 6 hours of arrival, participation in regional or national acute myocardial infarction registry, and risk score stratification for non-STEMI patient. Early invasive strategy we have in high risk non-STEMI patient, and therapeutic hypothermia for comatose STEMI patients with out of hospital cardiac arrest. Aldosterone antagonist at discharge, and inappropriate in hospital use of NSAIDs, and inappropriate prescription of prasugrel at discharge in patient with history of prior stroke or transient ischemic attack. Also, inappropriate prescription of high-dose aspirin with ticagrelol at discharge. So now we'll go for the indication of revascularization. Revascularization of the infarcted artery in patients with STEMI, class 1 indication in patients with STEMI and ischemic symptoms for less than 12 hours. PCI should be performed to improve the survival. Also in patients with STEMI and cardiogenic shock or hemodynamic instability, PCI or CABG, when PCI is not feasible, is indicated to improve the survival, irreversible, irrespective of the time delay from MI onset. In patients with STEMI who have mechanical complications such as ventricular septal rupture, mitral insufficiency, CABG is recommended at the time of surgery with the goal of improving the survival. Also, class 1 indication in patients with STEMI and evidence of failed reperfusion after fibrinolytic therapy, rescue PCI of the infarcted artery should be performed to improve the clinical outcomes. Class 2 indication also for the revascularization of the infarcted artery in STEMI. Class 2A in patients with STEMI who are treated with fibrinolytic therapy, angiography within 3 to 24 hours with the intent to perform PCI is reasonable to improve the clinical outcome. Also, class 2A indication in patients with STEMI who are stable and presenting 12 to 24 hours after the symptom onset, PCI is reasonable to improve the clinical outcome. In patients with STEMI in whom PCI is not feasible or successful with a large area of myocardium at risk, emergency or urgent CABG can be effective as a reperfusion modality to improve the clinical outcome. Lastly, in patients with STEMI complicated by ongoing ischemia, acute severe heart failure or life-threatening arrhythmia, PCI can be beneficial to improve the clinical outcome, irrespectful of time delay from the MI onset. Class 3 indication, no benefit in asymptomatic stable patient with STEMI who have a totally occluded infarct artery more than 24 hours after symptom onset and are without evidence of severe ischemia, PCI should not be performed. For the harm in patients with STEMI, emergency CABG should not be performed after failed primary PCI in 2 cases: in the absence of ischemia or a large area of myocardium at risk, or if surgical revascularization is not feasible because of a no-flow state or poor distal targets. This diagram summarizes the previous indication. Okay, for the revascularization of a non-infarcted artery in STEMI patients, class 1 indication in selected hemodynamically stable patients with STEMI and multivessel disease after successful primary PCI, staged PCI of a significant non-infarcted artery stenosis is recommended to reduce the risk of death or MI. In class 2A, in selected patient with STEMI with complex multivessel non-infarcted artery disease after successful primary PCI, elective CABG is reasonable to reduce the risk of cardiac event. For class 2B, in selected hemodynamically stable patient with STEMI and low complexity multivessel disease, PCI of a non-infarcted artery stenosis may be considered at time of primary PCI to reduce the cardiac event as long as hemodynamically stable. Class 3 harm in patients with STEMI complicated by cardiogenic shock, routine PCI of a non-infarcted artery at the time of primary PCI should not be performed because of higher risk of death or renal failure. Coronary angiograph and revascularization in patient with non-ST elevation acute coronary syndrome. Class 1 indication in patient with non-ST elevation acute coronary syndrome who are at elevated risk of recurrent ischemic event and are appropriate candidate for revascularization. An invasive strategy with the intent to proceed with revascularization is indicated to reduce cardiovascular events. Also, class 1 in patients with non-ST elevation acute coronary syndrome and cardiogenic shock who are appropriate candidate for revascularization. Emergency revascularization is recommended to reduce the risk of death. Lastly, inappropriate patient with non-ST elevation acute coronary syndrome who are refractory and who have refractory angina or hemodynamic or electrical instability, an immediate invasive strategy with the intent to perform revascularization is indicated to improve the outcome. For class 2 and 3, for class 2A in the same patient who are initially stabilized and are at high risk of clinical events, it is reasonable to choose an early invasive strategy within 24 hours over a delayed invasive strategy to improve the outcome. In patient with in the same patients who are initially stabilized and are at intermediate to low risk of clinical events, an invasive strategy with the intent to perform revascularization is reasonable before hospital discharge to improve the outcome. Also, in the same patients who have failed PCI and have ongoing ischemia, hemodynamic compromise, or threatened occlusion of the artery with substantial myocardium at risk, emergency CABG, who are appropriate candidate for CABG, emergency CABG is reasonable. For class 3 harm with the same patients who present with cardiogenic shock, routine multivessel PCI of a non-culprit lesion in the same setting should not be performed. Revascularization to improve the survival in stable ischemic heart disease compared with we are compared with the medical therapy. Left ventricular dysfunction and multivessel disease, multivessel coronary artery disease, class 1 indication in patient with stable ischemic heart disease and multivessel coronary artery appropriate for CABG with severe left ventricular systolic dysfunction, AF less than 35. CABG is recommended to improve the survival. For class 2A, with the same patient and multivessel coronary artery, appropriate for CABG and mild to moderate left ventricular systolic dysfunction from 35 to 50. CABG to include the left Lima graft to LAD is reasonable to improve the survival. For the left main coronary artery disease, class 1 indication in patient with the same patient and significant left main stenosis, CABG is recommended to improve the survival. For class 2A with the same patients, for home PCI can provide the equivalent revascularization to that possible with CABG. PCI is reasonable to improve the survival. Revascularization to improve the survival still in stable ischemic heart disease. The multivessel coronary artery disease class 2B indication in the same patient with normal ejection fraction, significant stenosis in 3 major coronary arteries, with or without proximal LAD, and anatomically suitable for CABG. CABG may be reasonable to improve the survival. Class 2B also the same patients, and anatomy is suitable for PCI. The usefulness of PCI to improve the survival is uncertain. Stenosis in the proximal LAD artery, class 2B indication in patient with stable ischemic heart disease, left ventricular normal EF, and significant stenosis in the proximal LAD. The usefulness of coronary revascularization to improve the overall survival is uncertain. For the single or double vessel disease not involving the proximal LAD, class 3 indication, class 3, no benefit. It shows no benefit in patient with stable ischemic heart disease and normal left ventricular ejection fraction, and 1 or 2 vessel coronary artery not involving the proximal LAD. Coronary revascularization is not recommended to improve the survival. For class 3, it shows harm in patient with stable ischemic heart disease who have more than 1 coronary artery that are not anatomically or functionally significant, less than 70% diameter of the left main coronary stenosis, and the FFR is more than 80. Coronary revascularization should not be performed with the primary or sole intent to improve the survival. This diagram summarizes the indications or the guidelines before. Okay, revascularization to reduce the cardiovascular events in stable ischemic heart disease compared with medical therapy. Multivessel coronary artery, class 2 indication in patient with the same patient, appropriate for either CABG or PCI. Revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularization, or cardiac death. For revascularization to reduce the symptoms, class 1 indication in patients with refractory angina despite medical therapy and with significant coronary artery stenosis, amenable to revascularization. Revascularization is recommended to improve the symptoms. Class 3, which shows harm in patients with angina but no anatomic or physiological criteria for revascularization, neither CABG nor PCI should be performed. Special population and situation. Revascularization in pregnant patients, class 2A, 2A indication in pregnant patient with STEMI, not caused by spontaneous coronary artery dissection. It is reasonable to perform primary PCI as the preferred revascularization strategy. In pregnant patient with non-ST elevation acute coronary syndrome, an invasive strategy is reasonable if medical therapy is ineffective for the management of life-threatening complications. Revascularization in older patients, class 1 indication in older adults. As all patients, the treatment strategy for coronary artery disease should be based on an individual patient's preference, cognitive function, and life expectancy. Revascularization in patients with chronic kidney disease, class 1 indication in patients with CKD undergoing contrast media injection for coronary angiograph. Measures should be taken to minimize the risk for contrast-induced nephropathy. In patients with STEMI and CKD, coronary angiograph and revascularization are recommended with adequate measures to reduce the risk of AKI. Class 2 indication in high-risk patients with non-ST elevation acute coronary syndrome and CKD, it is reasonable to perform coronary angiograph and revascularization with adequate measures to reduce the risk of AKI. Again, class 2A indication, with the same patient, it is reasonable to weigh the risk of coronary angiograph and revascularization against the potential benefit. Class 3, which shows no benefit in asymptomatic patient with stable coronary artery disease and CKD, routine angiograph and revascularization are not recommended if there is no compelling indication. Revascularization in patients before non-cardiac surgery, class 3, which shows no benefit in patients with non-left main or non-complex coronary artery disease who are undergoing non-cardiac surgery. Routine coronary revascularization is not recommended solely to reduce the perioperative cardiovascular events. Revascularization in patients to reduce the ventricular arrhythmia, class 1 indication in patients with ventricular fibrillation, polymorphic VT, or cardiac arrest. Revascularization of significant coronary artery disease is recommended to improve the survival. Class 3, which shows no benefit in patients with coronary artery disease and suspected scar-mediated sustained monomorphic VT, revascularization is not recommended for the sole purpose of preventing recurrent VT. Okay, revascularization in patients with SCAD, stable coronary artery, the class 2B indication in patients with stable coronary artery disease who have hemodynamic instability or ongoing ischemia despite conservative therapy, revascularization may be considered if feasible. Class 3, which shows harm and routine revascularization of the patient should not be performed. Revascularization in patients with cardiac allograft. It is a class 2A indication in patients with cardiac allograft vasculopathy and severe proximal discrete coronary lesion. Revascularization with PCI is reasonable. Situation in which PCI or CABG would be preferred. Patient with complex disease, class 1 indication, in patients who require revascularization for significant left main coronary artery disease with high complexity, it is recommended to choose CABG over PCI to improve the survival. Class 2 indication in patients who require revascularization for multivessel disease with complex or diffuse coronary artery. For example, syntax score more than 33. It is reasonable to choose CABG over PCI to confer a survival advantage. In patient with diabetes, class 1 indication in patient with diabetes and multivessel coronary artery disease with the involvement of the LAD who are appropriate candidate for CABG. CABG with LEMA to LAD is recommended in preference to PCI to reduce mortality and repeat revascularization. Class 2A indication in patients with diabetes who have multivessel coronary artery amenable to PCI and an indication for revascularization and are poor candidate for surgery. PCI be useful to reduce the long-term ischemic outcomes. In patients with diabetes who have left main stenosis and low or intermediate complexity in the rest of the coronary artery, PCI may be considered an alternative to CABG to reduce a major adverse cardiovascular outcomes. Patient with previous CABG, it's a class 2A in patient with previous CABG with a patent LEMA to the LAD who need repeat revascularization. If PCI is feasible, it is reasonable to choose PCI over CABG. In patient with previous CABG and refractory angina on goal-directed medical therapy that is attributable to LAD disease, it is reasonable to choose CABG over PCI when an internal mammary artery can be used as a conduit for the LAD. Class 2B in patient with previous CABG and complex coronary artery disease, it may be reasonable to choose CABG over PCI when an IMA can be used as a conduit to the LAD. For dual antiplatelet adherence, class 2 indication, class 2A in patient with multivessel coronary artery amenable to treatment with either PCI or CABG who are unable to access or tolerate or adhere to dual antiplatelet for the appropriate duration of treatment, CABG is reasonable in preference to PCI. These are my references, up-to-date AMBUS and HA and ACC guidelines. Thank you very much.
Thank you, Dr. Hani, for the presentation. Any question? So we'll resume the third lecture after 5 minutes. Thank you.
I'm sorry, I missed the point. Was there any questions there for Hani? Hello? I'm having some trouble with the connection, I guess. Can you hear me?
Yes,
Yes,
Dr.
Dr. Farid. Yeah.
Yes.
Okay. Did anybody ask any questions? I was disconnected for a moment here.
Oh, no.
Nobody asked. So
Yeah.
I have a question for Hani. You said one of your references is ACC, American College of Cardiology. So when was that published? Is he still around, Hani? I guess not, huh? Anyway, am I still on? Can you all hear me?
Yes,
Yeah,
Dr.
yeah. We hear you,
So
but I think
when
Dr. Farid, I think because the panel give us a time for the break, 5 minutes. So I
Okay.
think most
All
of
right.
the different, yeah.
Okay. Well, I was, in that moment, subhanAllah, I was disconnected. But something to announce for everybody that there's a recent guideline
Exactly, yeah.
that is everybody in disagreement with. Many surgeons are sounding their disagreement with it. And it looks like Hani may have presented some of the recommendations from that guideline. So especially for those seniors who are going for their exam this year, they should know about that controversy and they should know how to defend it. I mean, how to defend against it. Okay, thank you.
Thank you, Dr. Farid. But I think, Doctor, the latest guidelines, we have to adhere to it, right? I mean, it is internationally.
No, the most recent one in the ACC was written by cardiologists, no surgical.
Yeah, they didn't endorse, yes.
Yeah, and it's not endorsed by many surgical societies.
Exactly.
So if you're gonna mention this these guidelines, you have to be able to defend against it, which means that yes, it is the current guideline from ACC, but as a surgical entity, the SDS have this opinion and this guy has this opinion. So at least you should be aware of this controversy.
Exactly, yes. Sure.
Thank you.
Thank you, Dr. Farid.
We're starting the third lecture about syntax trial with Dr. Fatma.
Hello, can you hear me?
Yes.
Hello, everyone. So today I'm going to present the syntax trial, which was published in the spring 2009 by the New England Journal of Medicine, and it was sponsored by Boston Scientific. So why did they conduct the syntax trial? There were several trials comparing PCI with bare metal stents and CAPG in patients with multivessel disease. Those studies showed similar survival rates, but higher revascularization rates at 5 years in the PCI group. Also, there were studies comparing PCI with the drug-eluting stents and CAPG, and they were generally being smaller and non-randomized. The studies comparing the drug-eluting stents and the bare metal stents also showed that there was a significant reduction in the rate of repeat revascularization in PCI group with drug-eluting stents. And as the CABG was and remained the treatment of choice for patients with severe coronary artery disease and those with left main and three vessel disease, and there was a lack of data from adequately powered randomized trials of PCI in such patients, and also the most randomized trials comparing drug-eluting stents and perimetal stents excluded the patients with complex coronary anatomical features, PCI was performed in this group without adequate support from evidence-based medicine and randomized clinical trials. So the SYNTAX trial was developed to compare the relative efficacy of CABG versus the drug-eluting stent with PCI using Taxus stents in patients with severe three-vessel disease or left main who were eligible for both CABG or PCI. So the study design, it was a prospective, randomized, parallel, non-inferiority clinical trial, which was conducted starting in March 2005 through April 2008 with a clinical follow-up. The study had an all-comers design involving the consecutive enrollment of all eligible patients with three-vessel or left main coronary artery disease. They were around 1,800 patients who were randomized in a 1-to-1 ratio in either the CABG group or PCI with drug-eluting stents. The involved patients were enrolled from 85 different sites from different 17 countries in Europe and the United States. The study was approved by the Institutional Review Board at each participating center. So the primary endpoint was a composite major adverse cardiac and cerebrovascular events, including death from all cause, stroke, myocardial infarction, or repeat revascularization through the 12-month period after randomization. The secondary endpoints were death, myocardial infarction, CVA, and death from all cause. And also they added a secondary endpoints, including the overall rate of MACE and the rate of the individual component of MACE, 1 month after the procedure, and then 6 months, 3 years, and 5 years after the intervention. And also they included the cost and cost effectiveness, and also the quality of life at the same time interval. So regarding the recruitment or the enrollment of the patient, first of all, they screened around 4,337 patients. And out of those, 1,262 were excluded because they weren't eligible for several reasons. And then the assigned reviewers, the interventionists and the cardiac surgeons, they excluded 1,275 patients from those 3,075 patients to be enrolled in a nested registry, because 1,077 patients were unfit for PCI and they were included in the CABG registry. Other around 200 patients were unfit for CABG and they were included in the PCI registry. So the final number for the patients who were enrolled in the randomization process were around 1,800 patients. The inclusion criteria involved the patients who were 21 years old and older, patients with three-vessel left main or left main equivalent disease, patients with de novo coronary artery lesions, and patients with stable myocardial ischemia, and those with anatomy suitable for both CABG and PCI. Patients who were excluded from the study were the patients who had previous PCI or CABG, patients with acute myocardial infarction, and those who had concomitant cardiac surgery, and those who had participated or they were participating in another clinical trial, and the patients who were unable to give an informed consent. So after the randomization, a local interventional cardiologist and cardiac surgeon at each site respectively evaluated eligible patients with previously untreated three-vessel coronary disease and those with left main. And then all the diagnostic angiograms and electrocardiograms were reviewed by staff at independent core laboratory blinded to the treatment assignment. Diagnostic angiograms were scored according to the SYNTAX score algorithm. A SYNTAX score is a comprehensive assessment tool in which they were trying to stratify the participating patients into 3 different groups according to the SYNTAX score, depending on 11 elements. For each element, there is a specific score, and then they calculated. The 3 groups are the low SYNTAX score with a score of 22 and less, and then the intermediate with 23 to 32, And then the patients who scored 33 and more were considered to have a high syntax score. Several elements, including the presence of a total occlusion, a trifurcation or bifurcation lesions, the presence of ortho-osteal lesion, the dominance, the length of the lesion itself, the presence of heavy calcifications, the presence of thrombus, diffuse disease, the number of disease segment, and the tortuosity. So the patients were treated with the intention of achieving complete revascularization of all vessels. The surgical technique for CABG, the approaches used for stent implantation, and post-procedure medication regimen were chosen according to the local clinical practice. Regarding the treatment and the received medications, in patients who underwent PCI, antiplatelet medication was prescribed on the basis of the directions for use of the Taxus Express stent and local clinical practice. The aspirin was prescribed indefinitely for all patients who underwent randomization. And in most centers, the phenylpyridines were continued even after like 6 months, with 71% of patients receiving them for a duration of 12 months. I included the definitions only for referencing here. So comparing the general demographics or the patient characteristics in the two groups, the PCI and the CABG, generally saying they had similar characteristics. However, patients in the CABG group had higher levels of triglycerides and also higher levels of HDL. Also, there was a difference between the two groups and PCI and CABG in regard to time to procedure duration, and post-procedural hospital stay, and complete revascularization, which favors CABG patients. So regarding the medical treatment, there was a difference between the two groups regarding the received medical management. Patients in the CABG group received less pharmacological treatment than the patients who were in the BCI group, who were consistently treating with aspirin and antiplatelets. Here is a comparison of the primary endpoint between the two groups, the BCI and the CABG, at the time interval of 12 months. So initially, there was no difference between the two groups in terms of death from any cause. Also, there was no difference between the two groups in the stroke, or the overall cause of death and myocardial infarction. However, there was a clear difference between the two groups, the PCI and CABG, in terms of repeat revascularization. Patients in PCI group had higher rate of repeat revascularization with a statistically significant result. Also, the overall rate of MACE at the 12 months interval was higher in patients with PCI group, with a percentage of 17.8 in PCI compared to 12.4 in patients with CABG. So this table showed the same results which were illustrated in the Kaplan-Meier, with the addition of the graft occlusion or stent thrombosis, which didn't show any difference at the time interval of 12 months in comparison of the two groups. So the syntax trial have included another subgroup. There was a stratification of the patients according to the presence of 3 vessel disease, the left main, and the diabetes. So comparing the two groups, the PCI and CABG, in regard to the presence of 3 vessel disease, we can see a clearer difference in the overall rate of MACE. However, in the patients and the subgroup of left main, the results were not that clear between the two groups. And because of these results, 2 trials have emerged to answer the question of whether or not PCI is non-inferior to CABG. I think they will be explained later on with the Freedom trial and the Excel. So according to the syntax score, again, they investigated the rate of MACE between the two groups, the difference in the PCI and CABG. Patients who had a low syntax score and patients who had an intermediate syntax score, they didn't show any difference in the rate of MACE, overall rate of MACE at a 12-month interval. However, patients who had a high syntax score, they had a statistically significant difference in the overall rate of MACE at the time interval of 12 months, favoring a higher rate of adverse events with PCI, with patients in PCI group. So here's the follow-up after 3 years. Almost we had similar findings. The overall rate of MACE, again, was lower in patients in the CABG arm. The repeat revascularization was, again, lower in the CABG patients. However, the difference was the rate of myocardial infarction. At the 12-month interval, there was no significant difference between PCI and CABG patients in regards of myocardial infarction. Here, after 3 months, 3 years follow-up, the rate of myocardial infarction was higher in the PCI group. And the stroke, which was significant, which was increasing significantly in the CABG group at 12-month interval. Again, it was significant after 3 years, but without the rate was higher, but it wasn't statistically significant after 3 years. And comparing the two groups of CABG and PCI after the 3 years in the subgroup, again, patients in the subgroup with left main, there was no difference in the rate of MACE between the PCI and CABG patients. However, the patients in the subgroup of 3 vessel disease, they had a lower rate of MACE in the CABG group. Here is the results of comparing the two groups after a 5-year follow-up. So again, the rate of overall MACE was lower in the CABG group. The rate for repeat revascularization was low in the CABG group. Rate of MI, similar to the 3 years follow-up, was low in the CABG group. The stroke, also similar to the 3-year results follow-up, was higher in the CABG group, but without being as statistically significant. Okay. Also, the all-cause mortality showed no significant difference between the two groups. Here's a comparison of the two groups, the CABG and PCI, according to the syntax score after a 5-year follow-up. It differs from the 12 months result because the patients with low syntax score didn't experience a difference in the overall rate of MACE. However, the patients in the intermediate syntax score and high syntax score, they differ in several aspects, including the rate of MACE, which was higher in the PCI group, and also in the intermediate, in patients who scored intermediate score with syntax, and the patients with high syntax score, also the rate of MACE was higher. And here's the comparison for the subgroups after 5 years. Almost the results were similar to the 3 months. The patients with left and the left main subgroup and the CABG, there was no difference in the primary endpoints of MACE. The stroke was again higher in the CABG group with a statistically significant result. Repeat revascularization was again increased in the PCI group and the left main subgroup. Okay, for the 3 vessel disease, the primary endpoint, the MACE, was lower in the CABG group. All-cause mortality was again lower in the CABG group. Repeat revascularization lower in CABG group, and the stroke, they didn't mention about this the significant, but it was higher in the CABG group. And again, the repeated revascularization is higher with PCI in the 3 vessel disease subgroup. Then they had the 10-year follow-up. Comparing the mortality between the PCI and the CABG group, there was no a significant difference in the mortality. However, in the subgroups, there were a significant survival in the 3 vessel disease subgroup, favoring the patients with a PCI. So we have better survival in patients in the CABG group, and also in the second subgroup of left main, we had a better survival for patients who underwent CABG. The study limitations, the initial follow-up period was only 12 months, and most of the patients who were participating in this study were men. The patients who underwent CABG were less likely to receive optimal medical therapy than those who were included in the PCI. The investigators did not discuss whether the strokes were related to the procedure or influenced by differences in the occurrence of atrial fibrillation, use of antiplatelet agents, or presence of risk factors for atherosclerosis. So as a conclusion, the results of the Syntax trial demonstrate that in patients with left main disease or 3-vessel disease, CABG with the use of at least one arterial graft is superior to PCI with Taxus drug-eluting stent. This is especially true for reducing 12-month MACE rates, which were predominantly driven by the need for repeat revascularization in the PCI arm. CABG is, however, associated with a higher risk of cerebrovascular accidents at 12 months compared with PCI. Importantly, there was no difference in the incidence of death, myocardial infarction, or graft occlusion or stent thrombosis between the two arms. In the long-term results at the 5 years, a MACE rate was lower with CABG due to the reduction in repeat revascularization, lower rate of MI, and MI-related mortality. The cost-effectiveness analysis also demonstrates a benefit with CABG over BCI at 5 years. And from a quality of life standpoint, CABG was better than PCI in the incidence of recurrent angina. So ending with the study analysis, the question, I think it was an important question, hugely impacted the coronary revascularization process. But the design was international multi-center clinical trial. The sample size was adequate, even though they included only around 60% of the screened population. The conclusion was appropriate to the study result and the design. And I think it's widely applicable, especially in decision-making for patients who had complex coronary artery disease. Thank you.
Thank you, Dr. Fatma. Questions?
Assalamu alaikum. Are you taking a break now, or what's the plan?
I think it's better to have 10 minutes, Doctor, if you allow us, and also Dr. Mariam.
Sure. So you're expecting everybody to come back in 10 minutes for Dr. Mariam?
Exactly, inshallah.
Okay.
Dr. Maria,
أهلا.
can we start?
Okay, sure. Okay, good afternoon, everybody. Today we're going to resume the cases for stable coronary artery disease. According to the plan, this is targeted to the R7. However, if nobody is available from R7, we'll target R6 and then R5 and so on. So anybody from R7 here? If anybody is here, can raise his hand. Okay, I see Ahmed Al-Ghamdi. Anybody else? And Khalifa. Okay, we have 2 so far. Okay, we'll start with Ahmed.
Yes, Doctor, I'm ready.
Okay, sounds great. So how can I minimize this? Sounds good. Okay, so this is the case for you. You can read it.
Yeah, sure. So the scenario is a 62 years old female with typical chest pain. The ECG showed the T wave is inverted and she is positive for long-term hypertension. She is diabetic mellitus type 2 and dyslipidemia. She had a history of CAD with previous proximal LAD stent 2 years ago. So she was sent for coronary angiogram, and the angiogram showed that 50% distal left main at the bifurcation, and she had a proximal LAD with an stent stenosis of 80% and 50% mid RCA, 70 circ, and the OM1. So patient is insisting on BCI angioplasty. How would you consult the patients?
So before I ask you the last question, given that you guys just had the lecture, according to the presentation of the patient, why do you think this patient was not sent for stress test, but instead she was sent directly for coronary angiogram?
First, the patient, she is known case of CAD, and she's presenting again with ischemic chest pain with evidence of ECG changes on the and the, I don't know which lead, but she had evidence of ischemia. So this patient, and also the history of the stenting. So I would go for angiogram rather than put her on exercise. And also the age, I don't know if it is able to do stressing.
For 62?
Sorry?
Yeah, most of the 62 will be able to run on the treadmill, no problem. However, given the extensive risk factor for coronary disease and the most important, the history of a stent, with a patient presenting with typical chest pain and evidence in ECG, you're not going to refer for a stress test. This patient will go direct to coronary angiogram because you're worried about your stent, whether it is, has been occluded or if you have any new coronary artery disease, right?
Right.
Okay, excellent. So now I gave you the report of the coronary angiogram. Patient was on table. They did a coronary angiogram and found all those lesions. However, this patient is insisting on having to be restented for another PCI. So how would you counsel the patient?
First of all, I'm going to tell her that she already had a stent that failed after 2 years. The second thing is that the comorbid that she has, especially the diabetes, so the failing, it would be very high according to the FREEDOM trial. So as well as the left main, it is an indication for the surgery in this case. So I would give her the benefits of the surgery and the risk of the other alternative approach. And then I will let her to choose. It is her right to choose with whatever the decision. But I will actually explain to her the benefits of the surgery.
Okay. So what do you think the guidelines will state for this patient for coronary bypass versus PCI? Exactly. So the recent guidelines, it indicates if the patient have a left main, it is
a class 1 indication for cabbage. Patient with diabetes also, it is class 1 for cabbage.
Excellent. So she's like
And
for
three
sure
vessel
class
disease.
1.
Yeah. And three
Class
vessel
1
disease.
indication for bypass. Okay. You try to convince her, give her all the evidence. The patient is still insisting on PCI angioplasty. Oh, sorry. Okay, this is her angio. If you can read it and
Right,
confirm the finding.
Exactly. In this view, I saw the left main. It is okay. So this is the wire. Okay. Anyhow, this is an LED. It shows that there is a proximal lesion that is a severe lesion. I cannot illustrate this stent there in the LED. Yeah, and the LCX, it's had a lesion there. So this is the wire and the LED. Sorry, this is an LCX.
This is the wire. Where is the wire here?
Yes. So wait, just I cannot see the apex. So I think is this is an LED.
You think it's LED? This one?
No, this is an LCX. Yeah.
How did you know? How can you differentiate if this is LED or circumflex?
Actually, the course of the vessels, the atrioventricular junction. The second thing is the septal branches. There is no septal branches.
Yeah, so what is this?
So this is the LCX, yeah. Atrioventricular.
This is the atrioventricular groove, right?
Yeah.
How you show the curve of that. The other thing that can confirm if this is LAD is the view. What do you think? Which view is this?
I can't see the wire and as well as the spine, but I think this is an RAO.
It is RAO, yes.
Yeah.
Okay. And the LAD should be, if it's RAO, the LAD will be on the right side of the system.
Right side, yes.
If it's LAO, the LAD will be on the left side. So it will
Anterior.
Okay, so sometimes you have to imagine the views, and you have to remember in which view how does a vessel look like, because sometimes I agree with you, it might be confusing, especially if you have a significant collateralization or if you have totally occluded vessel, you may get confused. Okay, but there is a lot of tricks. The curves will confirm this is the atrioventricular grooves. Okay, the LAD, and you see sometimes the septal branches coming from the LAD. I'll run it for you to see.
As well as the apex, if I can.
And it's reaching the apex. So tell you this is the LAD. Okay, so we'll confirm here. What is this?
This is the LAD.
This is the LAD. And
yeah.
This
is the LCX, and this is the OM.
OM1.
Yeah, and OM2, and this is the distal LCX.
Okay, so we agree there is proximal LAD stenosis.
Yeah, as well as diagonal, I think is isolated.
Okay, what do you think is happening here?
This is they are doing angioplasty of the stent before. I cannot see the stent. Anyhow, this is an angioplasty.
Which vessel is this?
This is the proximal or mid LAD.
Okay, so what they're trying to do?
Angioplasty ballooning.
Okay, so they followed the patient's request and they're ballooning the LAD. Okay.
Okay.
I'm just gonna follow. Now they're putting the stent.
Sure.
There's multiple stenosis. Can you see the stent now? Here?
Yes. Yes.
Okay. So the stent is here, right? This is stent. You see it? Okay. So while they're implementing the stent, attempting to stent the LAD caused severe hemodynamic instability, ventricular tachycardia, hypotension, and cardiac arrest. You were called to the cath lab. Okay, it's called the blue and the cath lab, cardiac surgery overhead were called. How would you manage? And what do you suspect might happen?
First, I will manage the patient as the SLS protocol.
They're doing CPR. They're doing CPR. You're just walked into the room.
Okay. I think there is a rule of the temporary mechanical circuit support in this case. So whether to put intra-aortic balloon pump to augment the blood pressure.
You did? Okay, so you went ahead and you put the intra-aortic balloon pump. Okay, the patient is relatively stable right now. What do you suspect might happen? And how would you want to manage? Any recommendation?
I think that either the stent getting an early closure, or there is no reflow syndrome, I think, post stenting. So the LAD territory, I think right now it's in fact it's not getting enough blood. So I will actually accept her or send her for emergency CABG.
Do you want to do anything before you send her for CABG? The patient did not consented for CABG, remember.
And she's stable. I think you said she's stable, so I will consult
she's
her.
She's intubated. She's an intra-aortic balloon pump. She's on some nor-epi and epi.
So we have to do a family meeting with the family and then discuss.
Before in the cath lab, anything else you wanna do before, or ask the cardiologist to do?
You mean the echo or the preoperative workup?
Yeah, you have to stick a probe, right, and check for tamponade, for anything in the heart, right? Anything that you can intervene. So, okay, so you did echo, and there's small to moderate pericardial effusion, however, there's no tamponade. Have you heard about Ellis classification?
This is the perforation, right?
Yes.
Yeah, I think I've read it, but actually I'm not practicing it. So it's 3 types of Ellis classification. That is, I'm not sure, Wallah. I cannot recall.
Which one that usually we will get involved in? We hear a lot of like coronary perforation, patient and the CCU stable. When do we usually get involved?
If there is a perforation that's causing a tamponading effect.
So if it's tamponade, they will put pericardiocentesis. So this is the classification, the Ellis classification. Class 1. There's only crater extending outside the lumen, but there's no extravasation. So in this type, they observe, they do nothing. Okay. Type 2, it's there is a pericardial or myocardial flush with less than 1 millimeter exit hole. Okay. And this type also, like patient may be stable or unstable. So what they try, if the patient is stable, they will inflate the balloon and they will insert a cover stent.
Cover stent.
Okay. And it's in type 3, where there's active extravasation or perforation into anatomic cavity. This is a surgical indication. So again, they will try to temporize the patient by inflating the balloon. However, if you inflate it for a long time, if there is no flow to distal to the perforation. So if it's a proximal perforation, it might need surgical intervention. If it's distal perforation, sometimes they can coil it. So this is the algorithm. It really depends about there is extravasation or no. No extravasation, you can monitor the patient. Yes, extravasation, you have to treat. Large vessel perforation, you can try to cover a stent. If the patient, if it's tolerable, then it's okay. If not, continue to extravasate, you have to send him for surgery. Okay. If it's distal, if they perforate it very distal, they can coil. There is no significant, or there's no harm by just coiling or cover stenting the distal perforation. Okay, it's very important to know, because at some point you may get called for this catastrophe. Okay.
Sure.
Again, there's a controversy about whether to take the patient to the OR or to talk to the family. Of course, if the patient is directly unstable, you'd have to talk to the family and take it to the OR as an emergency. I'll go back to my presentation. Can you see my slide?
Yes, that's the tool.
Okay. So this is the patient now. She's on the intra-aortic balloon pump that you put, epi 0.05, not epi 0.07. So relatively is not high dose of inotropes.
She's maintaining
she's maintaining the map. What do you think? This is the screen for the balloon pump.
Yeah, there is and the inflation and deflation of the aortic balloon, and goes that the systolic is 90 over 42, MAP is 25.
I'm not going to go into details of this because I may ask you about how do you think the augmentation. So we can refer it to mechanical circuit support sessions. We're going to talk about, early and late deflation and inflation, all the details about balloon pump. But in general, for now, just for the topic, you're happy with the MAP, with the augmented blood pressure?
Yeah.
Okay. And this is the inotrope she is in. You talked to her family. She's intubated, and they agreed for you to go for surgery. The question is, do you want to take her to the OR immediately, or do you want to stabilize her in ICU first and take her later?
No, I will first stabilize the patient, ensure that everything is ready, blood for her as well. And then we're gonna put operate on her in the next early morning.
Okay, so you think she's stable to wait till tomorrow morning?
With this parameters, I think so, yes.
Okay, and what's your concern? The OR is available today. Why not to take her right now to the OR? What's the rationale?
Because the anticoagulation that she received during the stenting, it will be a high risk for bleeding. Second things that it is and it looks like an acute ischemia, so the myocardium, it will be it's ischemic, so I don't think that she can tolerate the protection.
Okay, all right, sounds good. So you wanted to wait till tomorrow.
Yep.
You booked her, you talked to the family, you booked the OR tomorrow morning. Overnight, she arrested. You did the echo, it's tamponade. Remember, she was having extravasation?
Sorry?
She was having extravasation from the vessel. And when you
And
did the echo in the cath
yeah.
lab, yeah, there was mild to moderate pericardial effusion.
Okay,
Yes,
so
so you have to look into all those factors. So either you have to put pericardiocentesis tube, so the patient won't tamponade overnight if you're going to wait till tomorrow, or you have to accept the risk of bleeding and take her to the OR immediately. Now, the practice that it might be controversial, I don't know, like, cons and pros for each of them.
Exactly.
The case that I was involved in with the coronary perforation, always to the OR immediately.
Okay.
Okay. But just
Okay.
keep in mind the other data, right? When you have, you needed the echo in the cath lab, yes, there was mild pericardial effusion, but it may progress, right, overnight.
Sure.
Okay. Okay, you took her to the OR. Now, how would you conduct the surgery? What's your target and conduit you're going to use?
Okay. So I will the targets for that, it's Lima to LAD, SPG to the OM. The right system, I think, is not involved, not that significant stenosis. So
SPG to the OM. Okay, 2 graft. Lima,
Yeah.
LAD, SPG to OM. Okay.
Yeah, but you said she's arrested. I don't know if the Lima at that time it's can be replaced with the SPG.
Yeah, that's a good point. That's what I was expecting you to say. Sometimes in hemodynamically unstable
Unstable patient,
recently arrested with untreated balloon pump and on inotropic support, sometimes you'd have to rescue the patient very fast by just taking veins and do all veins anastomosis. And that's usually what happens when the patient is unstable.
Exactly.
Okay, so you don't want to take the risk that you're trying to harvesting the memory and then the patient arrest again and you have to crash and bypass.
Okay.
Other people will argue with you, say it's okay. So this is, it's people will say, okay, I'll put her on bypass, and then I will take the memory. But it's it's difficult. You have cannulas in, and then you're gonna put the memory retractor, and it's not easy. most of the surgeon will agree that in this case, all vein graft is reasonable.
Okay, sure.
Okay.
Yes.
Alright. So I think that's it for the case. How do you think your performance?
Well, actually, that a little bit. Yani, I'm not. It like emergency, so I wasn't in like this emergency before. Anyhow, yani,
You learned something.
I have
When
to
you learn
expect.
something,
Yeah,
yes.
I have
Yeah,
to expect.
sometimes. So I think you did well in general when we discussed the indication for surgery. You know, this patient is indicated for coronary bypass according to the new guidelines, class 1 indication. You listed the trials very correctly according to syntax and the freedom trial, which is it's empowered for bypass surgery. And then we discuss about if the patient is insisting, against the guidelines, that you'd have to consent and document everything in your consultation note. That's even that it's according to the guidelines, class 1 indication to improve survival. The patient is insisting for coronary angioplasty, and then at the end is the patient choice. Then you read the angiogram very nicely. You were aware of the ELSA classification, which is great. You know, it's 3 grades. You just have to refresh your mind. I know it's not common practice that we go through them. So I know sometimes you have to read those rare classification just before your exam, but you're aware that the extreme form, it's a surgical indication.
Okay, great.
And then in terms of your management, again, you indicated that this patient, according to the patient or vital and stability, may need mechanical support, and your first step will be intra-aortic balloon pump. And then you mentioned also, like when we take her to the OR, I think the only things that you wanted to wait till tomorrow with the patient with mild pericardial effusion and active extravasation. So you forgot about the risk of tamponade. And then the conduit, you actually mentioned that you may consider only veins in this patient who's unstable. So I think in general, you did very, very well.
Oh, thank you, Dr. Mariam. Appreciate well everything.
No problem. Any questions then the other resident?
I have a comment, Mariam, may I?
Yeah, of course.
Ahmed, I think you did an excellent job. What level are you?
I'm R7.
No wonder. Okay. Very good. But also, if you would add to your armamentarium, asking for help whenever you're when you're hesitant or stuck or emergency or something like this, always ask. Sometimes it's available right around the corner or on the other side of the phone that they can help you with. So this is also encouraged in answering your exams as well.
Yeah, sure, doctor.
Okay, thank you.
Thank you,
yeah, absolutely. That's very true, Dr. Hugen. Thank you very much. They always encourage us to say, ask for senior help if we are in an emergency or a situation that you've never been involved with. Okay. We have another case if we have any volunteer from the R7. I think Khalifa, if he's still available.
Yes, Assalamu alaikum.
Okay, so you're ready for your case?
Yeah, let's go.
Mm-hmm. Okay, you can read it.
Okay, 59 years old male, stable coronary artery disease with positive stress test, where I think showing viable myocardium, and the coronary angio. This is a left chart showing LCX with distal disease first OM, and okay, this is LCX again. This is the left main. Can you go back?
Yes, absolutely. What is this?
Okay. This is a LCX.
And this one?
This one is usually the LAD there and the diagonal up and the LAD here.
This one what?
LAD.
Okay. And do you see any significant stenosis?
Yeah, significant stenosis proximal.
Okay. So far you
Yeah,
said
and no left main. No left main. There is a stent in the proximal LAD. Maybe.
Yes.
Mhm.
Okay.
This is all. I cannot see the right shot.
You'll see it now. Okay. That's it.
Okay.
You want me to repeat it or can you summarize your finding?
I think the right it's totally occluded. I can
Okay.
from this shot, and he has proximal LAD with LCX disease, so triple visit disease. 59 male with triple visit disease with positive stress test.
So cardiologists, they send their report. They say they agree with most of your finding. Osteal OM1, proximal LAD, significant stenosis. However, they reported the RCA small and just a small disease, like a small vessel.
Okay.
And the RCA. So they didn't identify any significant lesion in the RCA. No. According to the AHA level of evidence class of recommendation, what do you think we should perform for this patient? bypass versus PCR?
I think with the proximal LAD, we should go for CABG. And in the matter of level of evidence and class of recommendation, in ejection fraction, you did not mention anything about echo. But,
yeah, you can ask me and I can tell you. So they did an echo, which showed normal ejection fraction and no valvular disease.
Okay, what about the labs, troponin and BMB?
It's a stable coronary artery disease. Troponin is negative.
Okay. At that point, he is a two-vessel disease with normal ejection fraction with a proximal LAD. In matter of survival, I think he should go for.
What's the class of recommendation?
I cannot recall now for the class of recommendation, but in the proximal LAD, usually class 1, but they changed it here.
I agree with you. Two-vessel disease, including proximal LAD, used to be class 1 indication.
Yeah, but now it's changed. I don't. Yeah.
It was changed. It was downgraded to 2B. Okay,
yeah, but I don't know what I will go with.
For this
but
patient?
I will go. No, for the classes of recommendation, I will go with the previous one or the new one. So, but
yeah, for the exam, for the exam, if they ask you again, you would have to mention both. That's why with this a huge difference or downgrade of the guidelines, and as a surgeon, you have to mention to the examiner that you are aware that this indication has been downgraded to 2B. However, in the previous recommendation used to be class 1 indication. And given the fact that there is a lot of argument and about the new guidelines and lack of endorsement from the surgeon, you would say that this is a controversy, whether it's class 1 versus class 2B. But you just have to mention that you're aware of the new change in the guidelines and what it used to be before.
Okay, sure.
Okay, so we'd say this is class 2B according to the new guidelines. Okay, if let's say that we decided to take this patient for surgery, what's your target?
My target Lima to LAD and SVG to OM, and I could not appreciate the BDA. If the RCA is small, but the BDA sometimes it will be from the left system if the LCX is dominant.
What do you think?
Yeah, there is.
Where? So I'll go with you. This is a left main, right? What is
Yes,
this?
LCX.
This?
First OM, and this is second. This is the PDA. Oh,
PDA, yeah, which will come from the left system, right?
Yeah.
And
Yeah.
and this?
this is the usually in this view the LAD.
Yeah, this is the LAD and the diag.
This is
here.
diagonal.
Okay.
Yeah, straight.
Okay, so okay, you took this patient for surgery. You decided lima to LAD and vein to O1,
And vein to the PDA also.
and another vein to the PDA.
Yes.
Why? To the PDA?
LCX, it's not proximally diseased.
I don't know. You tell me.
No, there is not.
Okay, so it's normal flow through the
Normal,
circumflex, so there is no
Yeah.
flow to the PDA. The
Yes.
only disease it's in the ostial OM. So if you put
Yes.
a vein here, it will go down.
Agree.
Okay.
Mhm.
All right. So you decided for lima LAD and vein to OM1. I'm not going to go through why vein and not radial, the evidence behind it, because we discussed it last week. Were you there last week?
No,
Okay, so
unfortunately.
I would recommend you to go back to the recording because we have an excellent discussion about when to use the radial, the patency of the radial and OM. Again, I'm not going to fault you for choosing a vein graft for the OM, although if you put a radial to that OM, you would have a good patency given the significant stenosis in the OM. Okay, okay, you're on bypass, you can't find the LAD.
Sorry, come again. معلش
You're on
دكتورة.
bypass. Yes, you are on bypass. You went on bypass. You harvested the lima, okay, and you're ready to do the anastomosis. You can't find the LAD.
I cannot find the LAD.
Have you encountered
maybe-
this situation before?
Sometimes it will be intramuscular. You should allocate the LAD. If you could not, you will trace it through the diag, or you can go up and you have to allocate it before you are going to anastomosis.
Yeah, okay, so you can't find it. So what's the, ways or tricks that you can use to find the LAD? Like, through the service of the heart, when you just look, you can't find the LAD. So you said you're gonna what? Trace it from the diag?
Yes.
Yeah, which is true. If you see the diagonal, you're just gonna, open with the 15 blade until you find where's the
LAD.
The LAD, which the diag will come from, right?
Yeah.
Okay, and if you can't find the diag, any other way to find the LAD?
This is I have to allocate the interventricular groove, and usually in the proximal area it will be the LAD. It will be more superficial, so you can follow it from there.
But you can't see it.
Yeah.
Have you encountered this situation before in the OR?
I cannot see the LAD.
Yeah.
No, but there is some segment where it will be embedded in the muscle, intramuscular, but all the LAD, it's not visible.
Yeah, I will encounter similar situation before. We were spent like an hour just looking for the LAD and digging there and here and causing bleeding and just trying to find it. So it's very common in the exam, at least, that they may ask you, because it's possible that you can't find the LAD. You mentioned that if it's intramyocardium that you may not find it. Can you anticipate that pre-op?
Yes.
How would you anticipate?
From the angio and also CT. If you are
we don't have CT because usually we don't do CT before elective CABG.
Yes.
Unless otherwise indicated. So how would you anticipate a lady intramyocardium in the angiogram?
It will be angulated and it's deeper in the muscle. If you go back to the LED shot, maybe it will be clear, which I'm describing. Or
Okay.
okay.
Sorry.
Yes, this one. It's dual. Here it's dual system.
The LED is dual system.
Yeah, I can see it's branching like.
Okay. I've never heard about LED dual system. You mean like it bifurcates?
Yeah. I described it.
This might be a diag,
Okay.
and the LED is just continuous all the way to the apex.
Okay.
Okay, so how would you anticipate if the LED is intramyocardium? You said angulation. What do you mean by angulation?
If you see the proximal part, it will
Mhm.
be angulated down and straighten. This is the yes.
Yes, straighten, yes. So if it's straight, you know it's an intramyocardium, because usually if it's on the surface of the heart, it will curve like this way. So this is not a typical intramyocardium LED, but I'm just telling you. So this part might be intramyocardium because it's straight.
Yeah.
The other point that you can anticipate if it's LED,
I
you
will
see
go
if
to the
it's not
apex,
moving.
maybe.
No, in
What
the
about the-
angiogram, you will see if the LED is moving with the heart, whether moving or not. If it's straight and not moving, you know it's LED. It's intramyocardium. Okay. Now we'll go back to the question. If like you were concerned a little bit about intramyocardial LED and you went on actually bypass and you couldn't find it, so you said you were gonna trace it down from the diag.
Yes.
Any other tricks?
What about the apex?
Yeah. Okay. You can check the apex and see if it's resurfaced down there.
Yeah.
And then
Maybe.
you trace it with the 15 blade. You try to open the preaortic fat all the way up until you find it where you want. That's true. Other way, there's maybe 5 or 6.
Other way, it can. What now we are on the bypass. What about the plegia? If we are giving a plegia, maybe it will be appear or marking the target before you are going in bypass while the heart is.
How would you mark? If the LED is intramyocardium, you won't see it even if you are off bypass.
Okay.
But sometimes people would say, I'm gonna go on bypass, so if I'm digging around, if I like create a hole into the LV, then at least I'm on bypass.
Okay.
Okay. All right. So any other way, or you can think about it and text me or email me, or you want me to discuss it now, whatever you think. But there's 6 way to find it. Some of them are less common. The most common that you said, trace it from the apex or from the diag. Some would say, I will feel if this patient has a stent, proximal LED stent, and you actually mention it in the angiogram. So you can feel the stent by palpation. Okay, and where you feel it, you just go distal to it and try to open. The less common, I've never seen it, but it's mentioned in the textbook and some of the articles. And some of them will inject methylene blue through the aortic root, and it will light up with the coronary. Some would say, I'm going to open the apex. We could just make a slash cut in the apex and see where's the coronary. We get to transect basically the LED very distal, and you probe it with a coronary probe all the way up, and then you try to feel it with your finger, and where you expect your target or anastomosis would be, you're just going to open over the probe. Again, it's very dangerous. I've never seen it, but it's mentioned in some of the articles, and people will talk about it. Okay, and then you just like fix it distally, or ligate it or whatever, very distal at the apex. Okay.
Yeah.
So this is a very common scenario in the oral exam, that you can't find the LED and you have to list the tricks how to find it. Now, you finally found the LED, and while you're opening the LED, you'll accidentally cut into the back wall.
Yes. I will repair it. I will repair the back wall with
How would you repair it?
with a 7/0 or 8/0, and I will tie it outside.
Okay.
This is the maximum where I will do. Whatever.
So you're gonna put your sutures inside the lumen?
Yeah, inside the
and
lumen,
from-
outside. Then the other arm, I will go to the
So as a
other part.
horizontal
So I will
mattress.
fix.
Yeah,
Yeah.
as
I
a
fix
horizontal
the-
mattress, and you tie it outside.
Yes.
Okay. If I tell you that you actually open the back wall and then you are in the LV, you're very aggressive and you are in the LV, how would you fix it?
This will create a fistula. So I will patch it there.
Again, don't forget what Dr. Khouguer just mentioned. You can ask for help. If you've never seen it and you've never repaired it, you can ask for help. But in general, you can use the bludgeoned suture, again, similar way with horizontal mattress around the vessel below. So you go very deep, okay, and below the vessel, so you don't occlude the vessel. And then you repair the back wall separately with HOs, the same as you described. So you're gonna do two different repair.
So I will remove the LAD from the surface. And
No,
I will
no, you'll keep it. But with a bludgeoned suture, 5/0, you will go horizontal mattress beyond from below the vessel, right into the ventricle to the outside. And again, the second, I wish if I can draw it for you. And then you just ligate it behind the vessel without occluding the vessel, right? Below. And then you do separate HO, similarly as you prescribe, to close the back wall to two separate repairs. Okay.
Yeah. Okay.
So I think that's it. It was all. It's more technical case. I didn't give you a lot of history. Just like to read the angiogram and to go about a debate in the class in the recommendation, and you have to be aware and you have to know and prepare yourself like how to answer in the exam according to the different guidelines.
Yeah.
And then if you have encounter, because if they're not gonna give you in the oral exam like a straightforward coronary bypass surgery, they're gonna create a complication, and it's usually rare complication, and you have to know how to do it.
Okay, fair enough.
I think in general you did very well as well, Khalifa.
Thank you.
Thank you. Do you have any question or any others? Any of the other residents have any other questions? Dr. Khouguer?
Yes, I'm here. Again, I enjoyed the discussion so much. Khalifa, you survived and your patient survived. Thank you for saving his life.
Thank you, Dr. Farid.
Do we have time for more cases, or do you want to defer it to next week? Do you have another R7 who's willing to take one more case?
I think Dr. Rasha, she was here, she's R7, but she left. Who else? R7.
Okay, if nobody's available, it's up to you guys if you want the R6 to take the case, or we can defer it to next week.
If I may do another case.
Who's talking?
This is Ahmed.
Okay,
again.
No problem. If nobody's
Otherwise,
available.
I don't know if
What do you think, Dr. Khugair? Shall we defer to next week or?
We are trying to train the group here to stick back to the time, which is from 1 to 5, 4 hours, with breaks in between, of course. But I guess this is the second time we have those discussion. Very enjoyable. I'm enjoying it, and I'm sure Dr. Ahmed Al-Ghamdi and his colleagues are enjoying it too. They are asking for more, but maybe for today we'll call it off, and we'll start next week. Maybe we should stick more time. But let me ask you this, Mariam.
Yes.
We're supposed to make one of those 4 weeks each month to discuss the guidelines, or one of the not the guidelines, but one of the trials that you were alluding to earlier. So do you want it to be the first week of the month, every month?
Yeah, sure, that would be great. Yeah, that because we discussed syntax just 2 weeks ago.
Okay, so next week then will be another round of mock case discussion and presentation. Yeah, okay.
And then the week after we can discuss freedom trial.
Okay. Well, we can arrange it with Ahmed and his colleague. I'm not sure who's in charge of the of the scheduling, but yeah, they'll take care of you.
Dr. Zainab, she's on.
But she's not around, right?
Yeah,
I tried to reach her and she's not answering also her phone. Anyway, so you should always have a backup by somebody trying to should take the lead. Yeah, should take the lead and help rearranging this, because everybody else, you can see it from the attendance that you have really very good attendance up to now. It's almost 40 people around. So that's a very good attendance, and it looks like it's getting very interesting and very helpful for you guys.
Yeah, mashallah, Dr. Mariam, she did wallahi great. I really appreciate everything she said and the way she is delivering the information.
Wonderful. Thank you very much, Mariam. And I know you're assembling a big team of our colleagues, the young junior surgeons who are just have joined us from scholarship, maybe in the last 5-10 years. Anyway.
Yeah, we try to get a lot of people involved, so like different opinion and more cases for the benefit of the resident, inshallah.
Inshallah. Well, thank you very much for your efforts. It's really appreciated. Yeah.
Thank you very much.
Thank you.
Hello. Assalamu alaikum.
Salam.
Alaikum salam.
Sorry for delaying. Dr. Mariam, may I ask you a question?
Of course.
Yeah. In case of we couldn't allocate the LED, can we use the epicardial ultrasound to locate it?
Yeah, that's a very good question. You can use, usually you have Doppler, right? You can use the Doppler. However, if you are on bypass, you have to come off bypass in order to find it. Because when you bypass, you just have continuous flow. So that's one of the things that you can use before you go on bypass.
Oh, okay.
It's a very good thought. Absolutely. And Dopplers is usually available in the OR, and it's very easy to use.
Okay,
thank you so much.
Dr. Mariam, sorry. So if I really cannot find the LED at all, and I saw pre-operative, the angiogram, the diagonal is big and the ostium is patent. So I can graft the memory on the diagonal and that's it. Except
it's happened and I've seen it.
Yeah, I saw it once a time.
Yeah, if you can dig around and you can't find it, and the ostial diag is normal, so you can expect backflow into the LAD, right? Then it's okay. But let's say you have an ostial diagonal stenosis.
Yeah, this is
right. This is a big problem. Then you can't, because you're just like supplying the diag and the diag
lateral
distribution to the heart. But if it's normal, yes, you can put it and you expect backflow to the LAD. Or not backflow, retrograde flow to the LAD.
Okay.
You mentioned also looking at it in the root, right? Opening the aortic root.
No, the apex, from the apex.
So,
you draw.
we also, another option is to open the root and put the probe right through the left main into the LED and find, yeah. Another thing is, have any of you guys heard about doing the bypass to the coronary vein running beside the LED?
I
My
didn't
mistake,
see it,
sorry.
but I heard one of the consultants saying that it was bypassed. He has seen it himself.
I actually have done it myself at one time. We opened and we found the LED with difficulty, and once we opened the LED, it was miserable vessel. The patient was really ischemic. So what I did, I put the bypass to the vein and ligated the proximal part of it. The patient did very well, actually. 2 years later, the patient comes back still free of angina. So it's not like it was a thought of the moment. I didn't know that it was published, but when I looked it up, it was published before.
Oh, wow. I've never heard about it, Dr. Khalis. I'm learning something.
Me too.
Thank you very
I'm
much.
learning every day.
Testing.
Yeah. Okay. Well, we'll see you next week, guys. Have a good one.
Thank you. Have a good
Thank you.
weekend.
Yeah.
Thank you, Dr. Maria.
Thank you.